I was talking to these guys before the meeting about what it is, what a blessing it is to be able to take care of patients, because I'm not doing that anymore. And number one, I miss it, but when I was in the middle of patient care, I don't complain much, but I was frustrated from time to time with the electronic medical record, with people who didn't show up, with people who showed up 30 minutes late, which meant that there was already somebody there who was not late. And I mean, I don't have to tell y'all what it's like, but that ability to have someone look you in the eye and one-on-one really trust you as a human being, and for you to be able to serve them is something that not many people get to experience in any other profession other than being a healthcare professional. So don't give up the fight. You guys have to stay with it, because it's really, really not only important for the patients, but it's important for you as a human being. So anyway, stay with it as long as you can. I retired, and oh, before I forget, let me thank Rob and Marge for inviting me to come and speak to you guys. We set this up a few months ago, so I'm so glad we could work it out. And I know some of you, but I'll tell you a little bit about my story. I came to Atlanta 1986, joined one other hand surgeon, Frank Joseph. Some of you may know him. We added a couple doctors, and then we merged with Tom Price's orthopedic group, and then we ended up merging with Resurgence in 1999, and that ended up being a massive group, as you know, with lots of therapists, hand therapists and physical therapists. And I became president of that group for about 12 years, along with Dr. Wertheim, which you guys probably don't see his patients. He does knees and shoulders, but anyway. And then I decided after 30 years that that was a good number. I wanted to quit before somebody tapped me on the shoulder and said, hey, you know, it's time for you to go. And so right before I retired, the guy who was the senator in my district in East Cobb, representing East Cobb and Sandy Springs, decided to run for Congress, and he resigned from his Senate seat. And so I started getting calls from the Medical Association, hey, we need some more doctors down there, and you know, you've got the skills and you should do it. And it had never been on my list of things to do. But being stupid, I raised my hand and said, okay, I'll do it. And ran against 7 other people. This is in a special election in 2017, and won. And the first session down there really didn't exactly know what I was doing, but there were other problems, because we had a conflict between the chairman of the health committee on the Senate side and the chairman of the health committee on the House side, and absolutely nothing got done from the standpoint of healthcare. We passed one bill and the governor vetoed it. So it was really frustrating as a freshman in my 60s. To be a freshman is weird to begin with. But then this last year I had to run again, because it's every 2 years for Senate and House in the state level. And so that was a regular cycle. I had the same opponent that I'd had in the runoff the year before. And, you know, I'm still there. So the second year was different, because I did have some idea what I was doing. And what was really different about this session is we had new leadership. We had a new governor, a new lieutenant governor, who the lieutenant governor is the president of the Senate. We had 5 new senators, a total of 41 new legislators. And so you can imagine that things were shaken up. And so the lieutenant governor did me what I assume was meant to be a favor, and appointed me to be the chair of the ethics committee, which ended up being a nightmare, but that's another story. But anyway, this was a great session for healthcare. We passed, my count is 22 healthcare bills. And so that happened because the lieutenant governor made a change in the chairmanship of the health committee in the Senate side. And so Senator Ben Watson is running that, and he's a doctor. And I mean, imagine that. And so he worked very well with the chair on the House side, and we got a lot of stuff done. So hopefully that will continue. I am optimistic about that. And my committees are health, insurance, which I just got added to this year, which is very important because health and insurance really work together. You almost can't even separate them because many times there's coverage issues and so on that are really important to patients. And then I'm on the Military and Veterans Committee and chair of the Ethics Committee. So the Ethics Committee gets all the sexual harassment complaints, anything to do with lobbying, but the thing that really blew up my session was we got the voting machine bill, and that was a big deal. So between all of that, it was a very busy session. We did some things that I wasn't happy about that were not directly related to healthcare. I mean, they sort of were, but you know, being a go-to person on healthcare, there's some value there, and so I have decided to run again. For better or worse, I'm throwing myself on my sword for another, next year is the election year, for another 2 years, because we've got 3 doctors in the Senate, 1 in the House. And we've got some other folks that are, we've got a PA in the Senate, we've got 1 nurse in the Senate, a few in the House, a couple dentists here and there, but healthcare professionals are underrepresented down there when you compare it to all the issues we're dealing with that are healthcare related. And so that's why it's important, and that's really the reason I'm doing it again, because there's really nothing in it for me. I already had a great career, did not need another job, and you know, so I'm still there. I was going to go through a few things with you guys that happened this session, but I want to tell you, I don't want to forget to tell you that you can track a lot of things that are going on down there on the legislative website. And it's legis, L-E-G-I-S, .ga.gov, G-O-V. And you can go on there and find out who your senators and representatives are. You can contact them directly by email or get their phone number on there. You can look up a bill number, but if you don't know the bill number, you can search by keyword. And so you can find pretty much anything you're looking for on the website and find out if it's in committee, if it's, you know, past the House, but in committee in the Senate or whatever. Because it's really hard to get bills passed. And the way it works is I decide something's a good idea, I get our lawyers down there to draw up the bill, and then I so-called drop the bill. And that means I file it with the Secretary of the Senate. So then it gets assigned to a committee, and it will either get heard or not heard in the committee, depending on the whim of the chairman. And then if it gets out of committee, it goes to the Rules Committee. And after the Rules Committee, it goes to the floor in my chamber of the Senate. And then it has to cross over, which means it's got to go over the House side. So it goes through the whole same process. It goes back to committee on the House side, to Rules, then to the floor of the House. And then after all that, if it passes both chambers, then the governor has 3 choices: sign the bill, veto the bill, or let it become law without a signature. And he only has 40 days after the end of the session to do that. Our session is only 40 days long. So we start the 2nd Monday in January, and it's not consecutive. We kind of go along through January, February, and March with some days off here and there. And then we're done usually right around the end of March or early April. Then the governor has to sign everything by kind of the middle of May that he's going to sign. So it's designed to be a part-time legislature. There's bankers there, there's farmers there, there's lawyers there, teachers, I mean, you name it. There's pretty much one of everything. And it was set up like that deliberately to bring, first of all, you don't want people to be full-time politicians, but second of all, you want to bring a different expertise on different subject matter from all around the state. So there's lots of ways that can shake out. It can either be, it's not usually, on most things, it's not even party lines. It's not Republican, Democrat. It is rural versus urban. It is executive branch, that's the governor's office and all the agencies, against the legislative branch. There's power struggle there. I mean, there's local control versus state control. So there's all these conflicting tug-of-war things. And the one thing down there is it's all about relationships. So you probably ought to go on that website, find out who you're represented by in your district, send them a message. Say, hey, would you like to have would you have a cup of coffee with me? I'd like to talk to you about whatever. And if you do that during the off session, that's what I do with my representative when I was at Resurgence. Of course, it was part of my job as president to advocate for our practice. But most of them during the off season will meet with anybody, and you have to work around their schedule. And you probably you may have to go to the Capitol. The ones that are out in the state are not there, except for certain days. They may come up, and so I do meetings at the Capitol one day a week, and then I do meetings in my district 1 day a week. But it's not that hard to build a relationship with a state house rep or even a state senator. Harder at the federal level. Marge can talk to you about that. I was going to run through a bunch of these bills and tell you what we did, but the one thing that's important to know is that our budget is the one job that we have to do while we're down there. It's in our Constitution that we have to pass a budget. Our budget has to be balanced. Go figure. Seems like a good idea. All of us have to balance our budgets at home, but the feds, they don't balance their budget, they just borrow more money. But in Georgia and most other states, we do balance our budget. And the tricky part about that is if money goes to a program, it comes out of another program. And so it is difficult sometimes to have these budget conversations, but there are priorities that the state develops, and so far I think that process is run by people who really understand what they're doing. I don't agree with everything, but we put a lot of money this year into the disaster relief for South Georgia because they are still hurting down there. I mean, whole industries were wiped out, and the governor even called us back for a special session to get them some emergency funds because, as you may have seen, the feds did not get their act together and didn't get any money to the disaster hit counties for a really long time. I still don't know if they've gotten any money, but so that was important. And then we also passed the teacher pay raise, which was a big dollar item. And we also passed the voting machine bill, which I mentioned, because we have to replace our voting machines for the next presidential election, and that's going to mean a machine that has a paper trail. So there's a ballot that will print out when you vote on the machine, and then you will feed that into the scanner, and that paper ballot is actually the ballot that gets counted with when it comes down to an audit, and they keep those for 2 years. They have to keep them for 2 years. So that was $150 million right there. So, but we're talking about a budget that's billions of dollars. I don't remember how many. But we passed some healthcare stuff too. And one of the things that we've been working on, I say for a while, but this all started before I got there because I've been there for exactly 2 sessions. Rural broadband is a big deal. We've got all the broadband in the world up here in Atlanta, but in these little towns in Georgia, they don't have good internet connectivity. And what that means, they can't do telemedicine, which is really difficult because that's one of the solutions that we're looking at for trying to get access to people who don't have specialists, for example. And that bill actually was done because of military people who move around a lot and spouses that need to, move around with them. And so we passed several compact bills, and that was one of them. We put money in the budget for mental health, a lot of money in the budget for mental health, which I think we can all agree is a huge problem in our state. For trauma centers, for cancer, for maternal mortality, for retention of doctors in rural areas, for family practice preceptor tax credits, and residency slots, because we've sort of learned that people, because they go to medical school here, maybe gives them a little bit more of a chance of staying here, but if they do their residency here, that really increases the chances. So we got more residency slots. So some of that'll will help. But in terms of bills, as I mentioned, we passed a lot of healthcare bills. One of the most important ones is, and don't get hung up on these numbers, but I'm going to say the number in case you want to go look up the bill later. Senate Bill 106, that's the waiver bill, and it has two parts. One is the federal government allows states to do innovation, and they allow it in Medicaid, but they also allow it in the private insurance market. The one in Medicaid is called an 1115 waiver, and I'm not here to give you a lecture on waivers because that could take the whole time. But the other part is called a 1332 waiver, and that's for private insurance, because what we found out after the ACA passed is that a lot of the insurance carriers left the state and didn't want to participate in the exchanges because they couldn't make enough money because they had to put everybody in the same risk pool. And the 1332 waiver would allow us to create a reinsurance program to pull out some of the big claims to make it so maybe they would want to compete and come back into our state. The Medicaid waiver could, I don't know what that's going to look like. They've hired a consultant, and that could cover more people. But whether that's going to be something very specific or broad, it's all, I'm not sure anybody knows that right now. But that's an important bill. We also passed, anybody ever heard of certificate of need?
Yes.
I've been hearing about that since 1986. And it's, you know, certificate of need, just in a nutshell, is basically the state created this process where they get to decide whether a new healthcare facility is needed or not. And there's a whole bureaucracy around that down at the Department of Community Health. And the hospitals used to be divided on that. That kind of comes and goes, but they typically are not for it. They are for it because they want it to be regulated. The independent groups and practices don't like CON because they figure, you know, people should get to choose where they want to go, and the state shouldn't tell them. And so this year there was a big effort to kind of get rid of CON. That did not happen, but they really loosened it up some. And one of the things that happened in that bill, which is very strange, is the bill that we passed last year that then got vetoed, which is called the Health, it was called the Health Strategies Council last year, but they changed the name of it to the Office of Health Innovation and Strategy. I don't even know what the acronym is for that. But the problem down there is that all the agencies that are dealing with healthcare, they're in little silos, and they don't talk to each other unless somebody makes them. And so this creates a structure for all the stakeholders, and it operates out of the governor's office, where they will have to all get together on some regular basis and talk to each other about whatever, telehealth or whatever the subject is. So I think that's going to be really good for Georgia, regardless of what happened with CON or didn't happen with CON. We passed a step therapy bill, which I carried in the Senate, and you probably don't have to deal with that, but that is like if I want to prescribe Celebrex to somebody, but the insurance company makes them fail first on Motrin and Naproxen, you know, which may give them an upset stomach or whatever, but to do that, you've got to go through these steps. This really put some parameters around that, and that was a huge win for patients. So that passed. I had a bill that was the Interstate Medical Licensure Compact. I talked about the compact bills, and that just gives an easier path for somebody who wants to come in here. If they've got a clean record, you can get the data from the other state. And it's also protective for patients because it puts a background check provision in there, because we want doctors in Georgia, but we want the right ones in Georgia. We don't want any random person who lost their license in another state then lies on their application, and we don't have a way to find out. So now we will have a way to do that. Senate Bill 18 was my bill also. Senate Bill 16 was the one I just mentioned, but 18 was something called direct primary care. And what that is it means that if you are a patient and you either don't have insurance or you have a primary care doctor and suddenly they're not in your network anymore, or you're on Medicare and they don't take Medicare or whatever, you can contract with them directly for all your primary care in their office. And it doesn't cover imaging, it doesn't cover the hospital, but it can cover people with chronic diseases, and it's really reasonable. It's like between $40 and $100 a month. So for people who don't have insurance, it's a great option. Or if you on Medicare, but you don't want to deal with that and you want to do, keep your primary care doctor. So I was really happy about that. Shockingly, we passed 2 harm reduction bills, and harm reduction is sort of code for AIDS bills. And one is a needle exchange program, which I never thought we'd get done. It's been trying to get done for several years, and finally we passed it. The other thing is a PrEP pilot. PrEP is a drug that if you give it to high-risk people for AIDS, it protects them from getting AIDS. And that's going to be run through Department of Public Health. So both of those, the only reason we got that done, I feel, is because we're in the middle of an opioid crisis, and IV drug abusers are a high-risk group, and that's much more politically correct than other groups that we may have been talking about a few years ago. So that's why I think it passed, and I was very happy about that. We also passed 2 bills, and those were, if you're interested, House Bill 217 and 290. And then we passed 2 pharmacy bills because patients are getting screwed by drug prices, and a lot of times can't even get their drugs filled. So we passed House Bill 233 and 323, which are basically transparency bills that people can't be steered to certain pharmacies by their PBM. Do y'all know what a PBM is? It's a third-party pharmacy benefit manager. They're the middleman in pharmacies, and they're the ones, if there's a rebate from a drug company, they get the rebate, not the patient. And so we passed, it's basically we call it the anti-steering bill, but it's a transparency bill, so people know what's going on with the middle people that are dealing with drug prices. And then we passed something called Marge's Law, which was a dense breast tissue law, which requires that if your mammogram report has that on it, you're notified about that, because that might lead to some additional testing. We changed the name of the Physician Workforce Board to the Healthcare Workforce Board, which opens it up to, there are more and more physician extenders that are in the business, and it recognized that. You guys probably don't have to deal with the PDMP. That's a physician database. It's prescription drug monitoring program. And so basically, if I'm going to prescribe a narcotic, I have to query the database to see if the person, who else they've been getting drugs from, how many pills, who filled it, what date it was written, and all that. And although there was originally some pushback from the doctors, it's really a great tool, because you don't want to be giving drugs to somebody who's hooked on narcotics. I mean, it's just not, that's a loser for everybody. So we're going to change that program every year or two. We're going to beef it up more. And soon it's going to interact with the EMRs, with all the EMRs, so that you won't have to query one patient at a time. It'll automatically open that up when you get to that patient in your EMR. We passed this one really got some heat, House Bill 321. That's something called a bed tax that the hospitals pay, and they were all for it. Don't ask me why. It's money out of their pocket. But what was bad in that bill for them and good for patients is there's a transparency part in there that the hospitals have to post all their financial information on their website. And they really don't like that, but they're nonprofit hospitals. That means they get tax dollars, so they should have to disclose that. And so that's, I don't know when that takes effect, but that's ongoing. Has anybody ever heard of Kratom or Kratom? It's a supplement. You need to know about this. This is a thing, it's like a coca leaf almost. It's something it either comes in a powder, they buy it at the health food store or whatever, and it's like a stimulant. And you don't really know what's in there. I mean, like somebody gives you ground up leaves in a bag. I mean, you don't know what it is. But we put some restrictions around it that you can't buy it if you're under 18, and it has to be labeled what's in it, because people die from that. And many times it is a multi-drug situation, so it may not have been the kratom that killed the person, but it was part of a multi-drug overdose or whatever. So that's something you need to have heard of, and if one of your patients mentions it to you, it's not a safe thing, and they probably shouldn't do it. Telemedicine I talked about. We did pass several laws on broadband, and we passed a couple laws on telemedicine, and that sort of allow telemedicine. Let's see what else is important. Oh yeah, we formed a mental health commission. And that's the same kind of idea as the office of whatever I said before, where all the people that work on behavioral health have to meet on a regular basis because they're all working in parallel, but there's so much overlap on mental health, behavioral health, drug use, probation, criminal justice. It all kind of fits together. And so that's an important bill. And then we also formed a study committee on, which I'm on, about physician oversight of mid-level practitioners, because it's all over the board right now. Some people are nurse anesthetists, some people are PAs, some people are nurse practitioners that have a doctorate, others took an online course. I mean, so there's a lot of variability, and we need to kind of make it kind of all fit together. Two big bills you may have heard about, which I don't plan on spending a whole lot of time on, but House Bill 324, we're going to be growing marijuana in Georgia now. And that's for medical purposes, but you can write this down. We will see that move towards recreational marijuana in our state. So I'm not a fan, but we passed that bill, and just follow the money. That's all I can tell you. And then the other thing is 481, the heartbeat bill, blew up our whole session. I did not support the bill, but it did pass. I think it'll be stopped in the courts, and if anybody wants to talk more about that, we can. The one healthcare bill that didn't pass that was very disappointing was about surprise billing. Have you guys heard that term? So if you go to the emergency room and the hospital's in your network, but the ER doc is not, or the anesthesiologist is not, or whatever. The patients get stuck with these big bills 2 or 3 months down the road. So we've been trying to solve that since before I got there, and there's been politics in the way of solving that, because the Senate passes a bill unanimously every year that the Medical Association supports, and then the chair of the Insurance Committee on the House side shuts it down every year. And so the feds are now taking this up, and I don't know if Marge is going to talk about that, but there's a solution, and it's really about where do you set the bar of reimbursement. It's, again, it always comes down to the money. So we did not get surprise billing fixed. The other thing we didn't address, but I'm going to address it this year one way or another, is that one of the big insurance companies has a new policy starting last July that if you go to the emergency room with a problem and you think it's an emergency, but it ends up that it really wasn't a life-threatening emergency, they can deny your claim. They're going to deny your claim. Not based on your medical records, but based on the claims data, the code they discharge you with. Well, that's just wrong. And so there's lawsuits going on about that, and there was a study committee about that. There has been no legislation to try to stop that, so that's not really fair, because who knows why you're having a headache, right? It could be a stroke, it could be an aneurysm, it could be a migraine, who knows? So anyway, that's the kind of stuff we're dealing with down there, and so that's kind of a summary of the healthcare legislation we passed, and I think what you can take from that is that we did some stuff this year. You got to be careful, because you can pass legislation that is not a good idea. It's not easy to pass legislation, but sometimes there are unintended consequences, and you end up having to go back and fix it the next year. I'll give you an example. We passed a school zone camera bill last year on the last day of the session at midnight, 10 till midnight. And so everybody in the Senate kind of held their nose and voted for it because it was for the children, right? but it also, there were some connections in there that were a little murky and not really above board with the, well, I won't get into that. But anyway, we didn't think it had time to get through the House because we're supposed to stop at midnight. So our president of the Senate is standing there holding the phone, and they are still in session until 20 after 12 to pass that bill. And there's reasons that it was done that are all political and not in a good way. Well, after the bill passed, what we learned is it also changed the definition of a divided highway. So that if it doesn't have a median in the middle, like not just a turn lane, but a grassy median, you don't have to stop. Well, nobody wanted that. Nobody meant to do that, but that was the first bill we passed this year, was to go back and fix that. So there are lots of things that can happen with legislation, and that's where our founding fathers set it up, so it's not easy to get things through. And then the executive branch has to agree, and then the judges can still throw it out. And so that's why we have this 3 branches of government, is checks and balances, to keep one branch from controlling all the power and doing stuff that's detrimental to the country, the state, or whatever. So I'd be glad to take a few questions. I know Marge wants to talk to you about federal stuff, but I'd be happy to talk to you about anything.
A couple just points of clarity, and you don't have to spend a lot of time, but one was on the increase in residents. Is that like at state medical school, or how does that?
No, it just provides some funding for hospitals that want to start a residency program. And for example, Kennestone they started a residency program. There are some others that are starting around the state. And I think there is going to be another medical school in the state, but that's a separate issue.
Okay. And then the other one was, use the example of Celerax and having to go through trials and fail. But what would an MRI be? Because that's one that we get that issue, like they can't get an MRI. You know that they have something, but they have to fail us, or
Pre-authorization is still a huge problem.
Okay.
And I don't even know if we can fix that at the state level, because a lot of these companies are national companies that operate in multiple states, and they're third party, whoever's administering the TPA or whatever, they're in another state too. And so they may or may not be subject to state law. So some of that's really got to get fixed at the federal level. But the step therapy that I mentioned is specifically about medications, and it was very important to certain communities who have rheumatoid arthritis or Crohn's or something where these biologics are really expensive, and yet there's only really one drug. Chemotherapy drugs, the same thing. There's really only one drug that works, but sometimes time matters, and if the drug that they want you to try is going to hurt you, you shouldn't have to take it, right? So that's what step therapy did, but it didn't address the whole mess of pre-authorization.
I have a question. On your the bill where the patient can go right to the doctor if they're uninsured and have contracts with the doctor, how is that different than the concierge thing that's out there?
The concierge thing is different because the concierge thing, they're going to file your insurance, and they're going to charge you another $2,000 or $3,000 a year to provide VIP service, which allows them to take on less patients, but it gets you their cell phone number or whatever. They're still filing your insurance.
They are, okay.
The direct primary care insurance is not in it.
See, I didn't think with Medicare you could charge your patient and file Medicare. I thought that was against the law.
Say what now?
With Medicare patients, you cannot charge them and file in addition for Medicare. I think that's
Right, yeah. The concierge patients are not Medicare patients by and large.
Oh, I
They're,
thought that they were.
well, I think most of them are private, but that's cash. I mean, that's on top of the insurance, whatever the doctor's filing on your behalf. And so that's a cash transaction, but that's different than direct primary care, because direct primary care, you go to one of the doctors who does that, you can see them every single day if you want to, and it's going to be the same amount of money. Now, they can't handle everything in their office, and if you have something complicated and you got to go get an MRI, that's not going to be covered. So ideally, if you were going to do that, what you do is you layer it with a catastrophic insurance plan, so that if you have a car wreck on 285, you still are covered for that, but you don't need the Cadillac plan because you can get 80% of what you need from your primary care doctor. So it's just another choice. People need choices, you know. Everybody's situation is different, and there should be different ways to go about it. So anyway, this is a really hard job. I really miss taking care of patients, and I really appreciate what you all do every day. And if I can help you, I'm easy to get hold of. Rob or Marge can put you in touch with me. But please come down to the Capitol. Please come down and visit. I don't know if you guys have an advocacy day to come down, but you can come down any day. If you have a day off, just email me, and then I'll get someone to show you around, and you can kind of see how the sausage is made. All right, thanks for the invitation.
Anyway, I've been the chair of the Federal and State Regulations Committee for about 4 years now with ASHT. Prior to that, I was on the practice committee as a committee member in reimbursement. And the reason I got involved was because I had a business for about 10 years and in East Cobb, and I needed to know what was going on in reimbursement and how to fight those little battles that we have, because I didn't have an administrator over me. I was it. So I got involved, and you know, I asked a few questions, too many, and somebody thought, well, you could be the chair of a committee. So therefore, I became the chair of a committee. And fortunately, Marcia Lawrence, who is a PT, but ASHT, and really, really bright, very involved in this whole thing, was my mentor, and she helped me through. And so now she's gone on to other things, and I remain. So anyway, that's how I got involved in that. And I know if anybody managed to get to ASHT, I presented for the last couple of years on interesting things like MIPS and things like that, Merit Incentive Payment Program. It was so exciting. But apparently I was able to explain it simple enough that people could understand it. So real basic, just in case anybody doesn't know, the Affordable Care Act in 2019 pretty much got the ball rolling, and mandates from Congress come down to Medicare. Congress follows the law, which is the Affordable Care Act at this time, and that has not changed even in our current administration. That is the rule of the land as far as our Medicare reimbursement and the rules that are followed. And the main thing of that whole change really came down to patient-driven payment models, and they were trying to get away from fee-for-service and kind of the cafeteria style into more looking at outcomes and paying for reimbursing people for functional improvements in our practice. So we had two breakdowns. One was the MIPS, or the Merit Incentive Payment Program, which I'm sure you've all heard plenty of, and if not, I'll be glad to talk to you later, but I'm not going to go into that now. And that would be more appropriate for therapists. And then the APMs, or the alternate payment method, model, which is really for larger corps and hospitals and larger organizations, which we would not be able to participate in anyway. Anyway, so most recently, as a result of all this, this year we know that the functional limitation reporting codes were taken out of the requirements. That's one of the things that was done legislatively. And Medicare had these these G codes in there that we all are familiar with, I'm sure, to try to collect information to see whether or not what we were doing was actually making a difference in a functional level, and they couldn't find anything, and they couldn't relate it to anything, so it was useless, so they dropped it. And then, of course, this year we had the permanent repeal of the Part B cap, which we were all excited about because we tried forever, but it was just another regulation, and that was eliminated because they were eliminating a lot of regulations, and that's pretty much what it comes down to. Even though we fought really hard before, it finally just said, well, it's just a regulation, let's get rid of it. However, you do still have to do the KX modifier if you reach the cap of, or the amount of $2,010, which is a little less than the cap was last year for OT, and the combination of PT and speech. That hasn't changed. Somehow that was written up and never changed. So use a KX modifier if you feel like your patients are going up to that point. The other thing is that the claims are not subjected to mandatory medical review, but if you happen to reach $3,000, you are subject to an audit. Because they want to keep some management on how much you're charging and how long you're seeing your patients, since there's not a cap. The other problem to that is that it's pretty much a zero wash because there's no money in a department to do these audits. So you may not get audited, but I still think it's pertinent for us to stay ethical and make sure that our patients that are being paid by Medicare are coming as a result of their need for skilled treatment, not just as a gym, which I have seen happen many times. And now that we don't have a cap or somebody watching over us, we really have to be careful of that and make sure that you're documenting, that your certifications are done with your, every 90-day certifications are done, that your progress reports are done every 10 visits or 30 days, because all that stuff, if you are audited, they're going to look at that. And then as a result of the cap being removed, the backhand side of that is that the OT assistants and PT assistants are going to be reimbursed if they're treating Medicare patients at 85% of the fee schedule. So if Medicare allows $100, then you'll get $85 of that. So you're not going to lose 85% of $100. You're going to just get paid 85% of the already managed fee. And so in order to figure that out, Medicare has to put a modifier on when an assistant is being seen or seeing a patient in Medicare, and that will be happening in the year of 2022. But in the process, in the meantime, I know that AOTA and ASHT are working on trying to eliminate that or modify that. And they have a couple of years to do that. I don't know about APTA because I don't really keep track of that. But those are the things that are going on behind the scenes with your parent organizations to try to keep us getting reimbursed at a good level. Now, the HR 6 of the 115 Congress, which is very important to know the difference, which occurred last year. This was passed and it was signed by our president, and it's the Support for Patient and Community Act. And that came as a result of the opioid crisis. That was directly as a result of the problem that was brought to the attention of our country, that opioids are out of control. So see, and I read through that, and there's about 100 points on it. And so the one point that really, I think, affects us as therapists is this one, that Centers for Medicare Services must provide beneficiaries with education on covered alternatives to non-opioid pain management treatments, which is us and other practices. But that one particular statement really will impact us. So this requires the Secretary of the House and Human Services to support or to submit a report on ways to improve reimbursement and coverage for the multidisciplinary evidence-based non-opioid chronic pain management, which is us. So that's going to be really important to keep an eye on, and that just happened last year. And that puts us into the whole category of what is pain management, what is best practice. And so there was a task force that was made with Congress, and they had a final draft that included some of these various practices. And so ASHT, knowing this, because we have, by the way, we have a lobbyist now. A couple of years ago we did not. So we have a lobbyist, somebody who's actually going there and being in on the sessions and trying to make sure, kind of as a watchdog of what's going on. So, and a communicator, or a liaison. So if we need a letter drafted, that his legal department will draft it. We approve it, we read it. I have had personal comments on things that were drafted that actually have been changed because they missed something or didn't understand something. So it's still very pertinent to be involved in the committee. Anyway, so ASHT submitted some comments to this agency, and we're waiting back for the final draft, and that occurred January of this year. We were basically included in as an integral part of the treatment of as a critical role in managing chronic pain. So we're on the record, we're in print, and we are being considered by insurance companies, Medicare, as an integral part of treatment in chronic pain. So the best practice part of multidisciplinary approach of pain management would include restorative therapy, which is what we do, right? PTs and OTs, and then complementary approaches such as yoga, Tai Chi, Pilates, anything required in movement. And the important thing there is that those are types of movement therapy that can be incorporated in our clinics. And I know that There's some PTs and OTs that are doing yoga. Tai Chi has research to show that it helps with balance in elderly patients. I have read some research on yoga with back pain as far as improving function. Not sure that it really manages or decreases that chronic back pain, but it did show that there was a relationship to increasing function, which is really the big outcome that we all want. And then the really important thing in that other program that I was talking about, the HR6, there was a lot of things on mental health in there. They're really looking at the patient's history, and they're wanting to open up records to look at past mental health and family problems and all these things that contribute to the outcome of the interpretation of pain. So behavioral health interventions such as coping skills and cognitive behavior therapy, which is a whole thing in itself. But you know, as OTs in our basic training, we learn some of this stuff. We may be applying it mildly, but we might want to also look into it a little bit more deeply, and how can we provide that to our patients who just walk in as outpatients. So one of the other things that the committee at ASHT, the liaison, was writing was ways to remove regulatory and reimbursement barriers that may limit access to our treatment. And so they're still looking at that, and the clinical best practice is always going to be continuing to prove quality of pain in the current environment, and then also approaches to pain management, allowing the multi-module approach to acute pain in the preoperative, peri-treatment, and post-operative. So that, to me, means we need to communicate with our surgeons and make sure that they know that before they prescribe an opioid, they might try some conservative therapy, post-op or even pre-op, to bring that pain management down to a functional level or a manageable level before they prescribe an opioid. I have to tell you my own experience. My first hand got very, very swollen after the surgery. The bandage was on too tight, and I experienced a lot of pain. And I didn't know that this wasn't normal. And I just thought, well, what is going on? I have this swelling, and it felt like a knife in the middle of my hand. It was extremely painful, and it really concerned me. And I was prescribed Loratab, which I got filled, but I didn't think I would take. Well, I took a few, and it made me very ill. And so I thought, well, this is not good. So I went back to thinking, like, well, this is swelling, this is inflammation. I'm going to take Tylenol combined with ibuprofen. And it managed me much better than the Loratab, and it didn't make me feel sick. Once I got rid of that, and I went back for my second hand because I complained to the surgeon that I had so much pain in the right hand, and to please put the dressing on lighter. I mean, good thing you're not my surgeon, because I went in there, I'm like, I want to be awake, I want a vertical cut, I want horizontal, I want all this stuff. And I did, I had an awake surgery, and which is what I wanted. But he was fine, it was Dr. Pelchovich, he was fine with that. But when I went back and said I was really concerned about this hand, and I had a lot of pain and swelling, and my intrinsics are still painful, don't do it the same, don't put it on as tight. He didn't, but he also, then I realized he prescribed me Percocet, so he went up on the chain. I did not even feel that. I thought, I don't think I'm gonna have a problem, and I did not. When my hand thawed out from the anesthesia, the lidocaine and the other stuff, I had no pain, there was no swelling, it was amazing. I mean, absolutely no pain, other than maybe it's a little sore if I touched it, and that's what I expected. So I never filled it, and I didn't take it, and if I needed to, I took an ibuprofen. So I know that you don't need to go to the top rung of narcotics whenever you do surgery. Even if somebody complains of pain, there's alternatives. And of course, we're looking at behavioral approaches. So there's a lot of recommendations and opportunities here for therapists, I think, as a result of this legislation occurring. And we need to do more research. We have to do research. We are really not good at that, and we need to get better. Even if your research is taking observation of various types of patients and writing it down and comparing to what you did to this one to that one, and somehow writing it up in an article, case studies. That's still a form of research. We need to restore reimbursement from the Centers for Medicare and Services and other payers for non-hospital sites and services and other services to decrease the cost. Because I don't know about you, but if you've been in a hospital lately, it's pretty darn expensive for anything. And if you go to an outpatient clinic, it's not as expensive. So we want to make sure that Medicare is looking at reimbursing us for our outpatient standing alone clinics. And then, of course, we want to do research on various types of therapies as part of a multidisciplinary approach, which could include our yoga, tai chi, relaxation. I know that some of the things I've gone to on pain is just abdominal breathing has been very effective. So these are all things in our wheelhouse that we can use. And then, of course, to implement other things, like I said, by OT and PT. So most recently, in the last 2 weeks, one of the problems that came to our attention in the legislative and actually the practice division was some problems with reimbursement with orthosis. The DME MACs, the Medicare administration contractors or approved contractors, are the ones that we go through when we become a DME provider. Does anybody know how to do that? Have you ever done it privately, or you just work at a place that has it? You just work at a place that, okay, well, to become a provider, and I can tell you, and anybody that's had a practice could tell you, you have to jump through hoops and fill out a lot of forms. You have to now pay $500 and something to do it. Yeah, not always, but in the last 10 years you do. But if you become a provider, then there's these MACs, or these Medicare approved contractors that are like warehouses. They're the supplier warehouses that you put your billing through. Medicare has basically farmed that out so that there's a separate entity that pays for your or reimburses for your DMEs. Unfortunately, one of the rules in there is the same and similar rule. Have you run into that? Okay, so the same and similar rule, and it mentions it in some of the Medicare literature, is that if you provide, like, I don't know, an L3808, okay, like a resting hand splint, wrist finger hand splint to somebody, and because they have rheumatoid arthritis, and you want them to sleep in it at night, and then a year later they go back and they get, joint replacements. Well, they're going to need something made again, and maybe this time with outriggers, but it still falls in the same category. And so because you made another one just like it a year before, even though they've had surgery, their situation has changed, you put that bill through there and they can reject that because it's the same or similar, and you're not allowed to replace anything for 5 years. Now that particular aspect was written as a result of things like knee braces, beds, oxygen tanks, wheelchairs, that you're not allowed to replace durable medical equipment, but every 5 years. So that doesn't work for us. And so some of the people have been writing into ASHT saying that they're getting denied for making something that was similar to something that they made 5 months before, even though surgery was done or the patient's condition improved and they had to modify it or change it. And then I also question whether or not they're using the correct codes too. So what we're doing about it is that we have written up, and our liaison has drafted a letter after talking to us that we're going to be sending to Norton, is the MAC for the Northwest and some of the states in the Northeast, like up around New York. And that's where the problem's been occurring. Our MAC is a CGS, which is a completely different company. And it goes by regions of the United States. So we're in a region that is different than that one. So we're not sending to all of them, we're just sending to Nordian and CMS to see whether or not we can clarify that the orthotics that we do require remaking or remolding or supplementing before the 5-year thing because of our medical conditions and our acute patients that we see, and because of medical necessity. The doctor writes the order like, make this now. Even though you made something 5 months or 6 months ago, you have to do it now. And what are you going to do? It's almost medically incompetent to let the patient walk out, in my opinion, without what they need and damage the surgery or the condition that they have. So the guidelines were made for these types of things, and we're writing a letter. We got the letter just last week. I reviewed it, and everybody on the committee reviewed it. We made suggestions, and he rewrote it. In fact, they're having a meeting tonight about it. I'm just not there.
Can they add the words custom fabricated? Because that's the huge thing, because the person's body changes hopefully for the better.
Correct. Well, those are the things that we need to bring up, that they are customized and they are specific and they are medically necessary. The medical necessity is a big thing. I know, right? Yeah, and a knee brace usually isn't customized. So that is where it's kind of fallen into this dark. And I personally think that because Medicare has given these MACs the responsibility for doing, they're interpreting these things on their own. Because if they don't have to pay us, guess what? They get to keep the money. So then the last thing is, I just picked this up on July 1st. United Healthcare is requiring modifiers for what they consider all codes. And all codes in their language is, no matter what, it's a therapy code. 97110, therapeutic exercises. They know if that code comes through a therapist or somebody, it's for exercise. So Medicare requires this now, and now United Healthcare is going to require this, and it's just a little bit of a little crumb to go back to your administrators and let them know that you're going to have to use the GN, GO, and GP, which defines whether it's a PTO to your speech, and that's so that when they're reimbursing, they can look at the patient's policy to see whether or not they have OT covered or they have speech therapy covered, and deny it if it's not. And so that's just happening, and they're going to implement that as of September of this year. Anyway, so that's all that's going on with me, and I just love reading this stuff and trying to figure it out. So, any questions?